updates for DHCS. Thank you. In the beginning, and then we're actually going to really focus on a discussion to get your all's feedback, which will be going directly to DHCS. So this is a really great time if you have like things you've been dying to tell the policymakers about ECM and CS. This is your moment. Of course, it will all be anonymized and can't be traced back to you, but this is a great time to do that. So welcome. Just a few housekeeping things. First off, if you can update your Zoom name to include not just your name, but also your organization, that really helps us and helps your fellow stakeholders to know who's in the room.
Okay.
And thank you to those of you who are on camera. I love that. I love seeing your faces, and particularly when we get into our discussion, that'll be, oh yeah, thanks, Lauren. That'll be particularly valuable. If you want in the chat to share a highlight of your New Year's celebration, or if you were lucky enough to take time off over the holidays or over the new year, a highlight of something that you enjoyed, we'd love to start off on that foot. And then please feel free to use the chat throughout the next hour. We keep all of the info from the chat, and it's really helpful both during discussions and also as we look back and kind of take count of your feedback and your input and kind of what's most relevant to you. So. All right, and with that, I also want to welcome any new folks. I see a couple of new faces, so thank you for joining us. We're excited to have you, and of course, thanks for our older folks, our 2023 veterans as well. We're excited for this next year of the Northeast CPI. The point of this space is really for stakeholders involved in the Northeast region, involved in ECM or CS implementation to come together. We can align on identifying challenges that you may be experiencing, problem solve, and in particular, this is a valuable space to uplift either issues or solutions to DHCS. That's one of the primary purposes. So please think of us as kind of a helpful path in giving voice to your experience on the ground, to the folks making policy at the state level. I do want to point out there's a link here where you can access all of our project materials, which is to say all of the slide decks that we've shown in the past year, all of the materials that we have. And so if you're new to the space, I encourage you to click there and take a look, and we will send out all of this slide deck and all the materials after the meeting as well. All right, and with that, I'm going to pass it over to our wonderful Eva, who's going to walk us through our objectives and agenda for today, and we'll get started.
Thanks, Gabrielle. Hi, everyone. Thank you for being here on a Tuesday afternoon after many meetings. So we'll get started with just clarifying our objectives for today. By the end of this session, you all will receive important updates about DHCS policy. You'll have a chance to share feedback for DHCS, as Gabrielle mentioned. And we'll also have the opportunity to hear the experiences of other stakeholders related to the 6 priority areas that have been identified. So we're doing some level setting right now. We'll talk a bit about what to expect in 2024. We'll move into some resource sharing, where we'll share some updates from DHCS and reiterate a few important deadlines and resources. And then we'll have some opportunity for discussion for everyone to share feedback on those areas, on those priority areas, and then we will talk about some next steps. So first, we would just love to get a sense of who is in the room. So I'm going to launch our first poll, and if you could just indicate which county you're joining us from today, that would be great. So I just launched that. And I'll give it a few more seconds. Thank you, everyone, for filling that out. All right, I think we're just about there. So we can see today we have a good amount of folks from Shasta, a couple from Siskiyou, and about 5 said several counties, including Shasta. Great, thank you. And then we just have another one just to see if we can get a sense of how many sessions you all have attended. I'm gonna go ahead and launch this. So previously, if you've attended 1 through 4, 5 through 8, 9 to 12, or if this is your first session. I'll give it a few more seconds.
Nice. We've got a couple of folks who this is their first session, so extra welcome to you.
Yeah, it looks like it's all across the board. Quite a few folks 1 through 4. Yeah, and then welcome to those who are joining us for the first time. All right. And then we have one more poll just to finish up our level setting here. And then this one really speaks to your role in CalAIM. So where are you in the contracting process? Just to give us a clearer idea of who we have here today. I'll give it a few more seconds.
And it looks like we've got kind of a mix of folks, which is really valuable. It's great.
Yeah. Great. Well, thank you all for sharing your responses to those questions. It really helps us understand the group that we have, make sure that everything that we're sharing is as helpful as possible. And I will pass it over to Gabrielle.
All right, thanks. So really quick before we dive in, particularly for those of you who are new, we wanted to just review a little bit of what this group was up to last year and what you can expect in this year to come. So last year we started the year and spent kind of a good chunk of the first half just trying to understand what you as stakeholders were going through as you were working on ECM and CM
it's riveting.
implementation, particularly identifying issues that you were experiencing. We did several sessions where we talked about different tools that you can use to do quality improvement. One of those is what we call the PDSA, or Plan, Do, Study, Act, which if you have questions about that, we love talking about that. So please let us know. We're happy to set up individual time with you. But that's really just one of many tools to think about as we develop programs and processes, how to continuously improve those programs. We then uplifted a lot of what we were hearing in this space to DHCS, and along with all of the other CPIs in California, DHCS responded with a policy update in July. A lot of the updates that came out of DHCS were in direct relation to the feedback that folks were uplifting in the CPIs. So it does go somewhere. And then we rounded out the year really talking about best practices, chronicling those. There's a link on this slide, as well as later in the slide deck, for kind of all of the best practices programmatically that folks in this group and related CPIs have come up with together. So really encourage you to take a look at those if you're looking for some ideas. And then in terms of next year, or this year that we're currently in, where am I? Let's see, we'll do next slide, please, Eva. Thank you. So what we're going to be spending the next few months on today, again, we're really focusing on a discussion to uplift your all's feedback directly to DHCS, centered around some priority questions that DHCS has. We're also in the process of mapping stakeholders in the Northeast to get a sense of who's at this table and who maybe would want to be or should be. And then part of what DHCS asks us to do at the top of each year is to set a regional goal. So we'll be doing that in coming sessions to try to collectively identify kind of what we want to accomplish in this space in the next year. And then what you can expect for the rest of the year is, first of all, we're putting together a program to bring regional subject matter expertise directly to you as a resource. So more to come on that. It's still in development, but you'll have an opportunity to get one-on-one coaching from some of your peer partners in the Northeast region who may have best practices or kind of hard-won lessons that they can share with you. We will also continue throughout the year to uplift your voices to DHCS, and particularly if you have recommendations about policy changes or things like that. We'll continue to be identifying best practices and just kind of, seeing what all is needed in the area and being available for that. So there we go. All right, well, we will now jump into some important updates from DHCS. I will warn you, Eva's gonna breeze through these fairly quickly, but all of these have links in them, and we are more than happy to set up time with you to talk through them more, or to talk through them more during the established office hour times. So do not worry if you miss anything here. We're happy to spend more time on it, but we really wanted to breeze through these so that we get a good discussion going today. All right, I'll pass over to Eva.
Thanks, Gabrielle. So the first update is a bit of a rebranding update, that CalAIM is now Medi-Cal Transformation. DHCS has rebranded its website and related documents to reflect this title. So if you haven't already seen this, when you see this, you'll know that it's the new name for CalAIM is Medi-Cal Transformation. We also want to give you a couple important updates on some funding opportunities. The applications for Cited are currently open. The window closes February 15th. The link to apply is there. And then TA Marketplace has rolling applications through 2026, and the link to apply will be in the slides as well. Additionally, we have linked the funding worksheet that sort of gives you an overview of what the sources are, what the process is for application, allowable usage, and then also the DHCS funding sheet is there as well. Another thing that we just want to highlight pertaining to funding is that today in office hours, we will have Visions of the Cross joining us. Office hours are taking place directly after this session. And Visions of the Cross does have a lot of technical experience applying to different funding streams. So if you have some questions about that, or just want to talk about what that process looks like, if you want support, feel free to stop by those office hours right after this session. We also are hoping to just get a sense here about the funding streams that this group is planning on applying for in 2024. So I'm just going to really quickly launch this poll to get a sense of what those streams are. You can choose multiple. So if you are applying to multiple in 2024, please just check all that apply. And I'll give it a few more seconds. All right, so I'm going to go ahead and close that out. And so it looks like we have a mix, a lot of folks applying for Cited and TA Marketplace. Great, thank you. Thank you for that. All right. The next updates pertain to billing and coding. Just an update that ECM providers can now bill for multidisciplinary team conferences occurring between the ECM lead care manager and one or more other providers associating with managing that member's care. The HCPCS guidance is linked there for additional details. We also wanted to uplift that unsuccessful outreach can also be billed using the ECM outreach codes, whether or not you're able to actually get in touch with the member. Like I mentioned, the HCPCS coding guidance is linked there for additional information and updates related to ECM definitions for both clinical and non-clinical staff. And then we have a couple updates here pertaining to the new populations of focus and the eligibility requirements there. For our birth equity population of focus, this pertains to adults and youth who are pregnant or up to 12 months postpartum and are also subject to racial and ethnic disparities as defined by the California Public Health data on maternal morbidity and mortality. And the ECM policy guide will be linked in the slides for additional details related to that population. We also wanted to flag that there is a webinar on this population of focus taking place on February 2nd, hosted by DHCS, and that link to register is included as well. Also want to touch on the justice-involved population of focus, which includes adults and children who are transitioning from or transitioned from a correctional facility within the past 12 months. And have at least one of 7 conditions outlined in the ECM policy guide. Children and youth who meet the criteria number 1 do not have to meet any additional requirements. So again, just a really brief overview of the populations of focus, but all of the resources with additional details are linked there. And then one more important update on transitional care services. That lower risk members can now receive support with a lighter touch approach. And the population health management policy guide is linked there with additional details about the released modified guidance on transitional care services. So we know that was a ton of information, and as you dig into it, I know there are going to be a lot more details and questions, and so we just want to make sure that you know that our team is available to really dive deeper into these updates and these details. We're always welcome to have a one-on-one with you or your team, so please always feel free to reach out to me to schedule some time so that we can learn kind of where you are on the journey and how we can support you with the, wherever you are in the process, support you with moving forward. And I will pass it back to Gabrielle.
All right, so we're going to jump into our discussion portion of today, which is pretty much the rest of the hour. So next slide, please, Eva. So as many of you are likely already aware, DHCS has set out for the CPIs 6 different what they're calling levers. So, never missed an opportunity for an additional piece of jargon. So lever really just means priority area. And we can go ahead and kind of show those, please. So the priority areas that DHCS has outlined for these CPI groups are standardizing eligibility, streamlining referrals and increasing sources. Again, this is all related to ECM and CS, streamlining authorizations, expanding provider networks and streamlining payments, strengthening market awareness, meaning both awareness in the community and among medical providers who might refer patients, and then improving data exchange. And I would add as kind of an asterisk to that, reducing administrative burden. So that's what we're going to be focusing on today. For those of you that are part of the SHARC ICC group, I want to extend a ton of gratitude. We met with that group earlier this month and posed some of these same questions and already got some really rich feedback. So thank you. For today, in an effort to not duplicate efforts, we are going to, instead of starting with lever 1, we're actually going to start with lever 6 and go backwards, so that hopefully this won't be too much of a repeat if you were at that SHARC ICC discussion earlier in the month. So with that, let's jump in. There's a few different ways to participate in this discussion. So first and foremost, we'd love to hear your voice. So please put yourself off mute, share your thoughts, raise your hand. But we also understand that not everyone is comfortable with that. So please feel free to use the group chat as well. We will be monitoring the chat throughout. And then if you have thoughts that you don't want to share with the whole group, we totally respect that. Please feel free to email Eva or I directly. Again, the idea here is to gather as much on the ground experience and feedback as possible. We will then anonymize all of that and send it to DHCS in kind of a packaged format. So we'll see what are the themes that are coming out from these discussions. And in particular, if you have specific recommendations that you'd like DHCS to consider. And we'll go through kind of what that might look like. So please feel free to participate, whether it's speaking, writing in the chat, sending us an email. We really want to hear your voice and be able to uplift that directly to DHCS to inform future policy. So with that, let's dive into what is actually lever 6. So again, we're starting from at the end. And this is all about data exchange. And I would again add, per feedback that we've heard already locally, data exchange / administrative burden. So these are questions that DHCS put forward directly. So what ongoing challenges related to data exchange and billing are you seeing, are you experiencing? What approaches have been effective in addressing those challenges? Or what approaches would you like to see, things that you'd like to see change in that along that topic? And then how are both the health plan or partnership and providers leveraging the admissions, discharge, and transfer fees for ECM? And I see that we've also got let's see, Lisa from Point Click Care on here. So this will be a relevant conversation. So why don't we start off there? And yeah, anybody who has any feedback that they'd like to be uplifted to DHCS or just topic to discuss in the group related to any frustrations or successes around data exchange or the administrative burden that you experience in implementing ECM or CS. Great, thanks, Eva. This way we can kind of see one another.
Hi, this is Chris. I had to take my video off because my internet is super unstable, but hi guys.
Hi.
So one thing that we've kind of noticed more as an issue recently as more and more people are becoming ECM providers is the monthly reports that we are getting. Some of the ones that we get may have been recycled. Maybe there's another provider who had them before we did. And so when we go to put them on our ECM program, then all of a sudden they're on another ECM program. Okay. And we're not sure how to make sure that stuff is getting updated inside of Point Click Care before somebody else is getting involved in that person's case. And I've already started the conversation with Ashley about this just today inside the very last meeting. So I don't want to put them on the spot with this, but we started to notice this happening a lot more in the last couple of months. And if there was a way for us, if we get our own community resource referral, that we can go into Point Click Care and just already mark them as somebody that we're engaging in outreach, then it would make it easier for other providers who are potentially looking up patients if they don't already have a profile there.
Right. Thank you so much for sharing that, Christina. Ashley, I'm curious if you have thoughts.
I don't have thoughts. I told Chris in our last meeting I'm super curious, and so she's going to provide me with some member information so we can look into it. I'm not sure if it's something that we'll have to take to Lisa and Point Click Care to look into, or if it's something that the ECM team can fix with maybe an assignment process or a file that's being uploaded. So we'll definitely follow up after we look into it.
Awesome, thank you. And Christina, can I just ask, is it do you know if the members are actually actively engaged with that other ECM provider, or is it just that like on paper they're engaged, but really in practice they're not?
Well, what we saw, this is the most recent case that we saw, is that we actually went out to do the in-person visit to put the person on the program, the actual intake visit, on the 6th of January. And when we went to, after we had all the paperwork together to go submit it and do a TAR and everything else, then we went into point-click care, and all of a sudden the person showed up and it said they were assigned as of the 5th to a different provider.
Oh no.
So, and some of our members too, we have a wide range of different types of members out there. So some of them are, more understanding of what kind of programs they're getting involved in, and other ones maybe not so much. So sometimes you're speaking with somebody with dementia for one case, and they may not remember, they just talked to somebody yesterday about the exact same program. So that happens where we end up getting multiple people involved in the same program. So that's challenging.
Yeah. But just highlights the importance of being clear about who's involved with what programs and what providers. Yeah. Andrea, I see that your hand is up.
Hello, it's Toby.
Oh, hi, Toby.
One of the things that I've found too is in the same thing that lady was talking about is what I have found is if I don't see an active care plan or ROIs in there, it's showing me that they're maybe just being out in outreach, so they haven't actually started those services with them. So when I have a member like that, I have them contact whoever it is that they've been assigned to either start services with them or to request to start services for them to stop the services on their end to be able to start services on our end. But one thing that I think would be beneficial if there was a way to maybe time sensitive when somebody requests to stop services with another provider that they haven't started in yet, that other provider, once the participant contacts them, like they have so much time before they have to submit the cancellation of services to partnership. That way the next provider can pick them up, especially like she was saying, if it's still the beginning of the month, if they can go back, that still gives them time to be able to access those services through Dignity for that month, and not have to wait a whole nother month to actually give this person services. Because what I've found is most of the time is like it's just in the referral process and they haven't even started those services yet. And sometimes these services are in immediate needs for these members too, to be able to access those services, because I think sometimes it's doing more harm to prolong it, to be able to access the ECM services.
Right. Yeah, no, we definitely hear that. Great. Thank you, Toby. Lisa?
Yeah, hi, thanks. Nice to see everyone and exciting to talk to you. And I know that we probably already addressed this, so most folks already know that we get one file per month from partnership over to Point Click Care, usually around the beginning of the month, so within the first few days. So that kind of like sets the assignment for the month. But what I can suggest for folks, especially if you're doing outreach, maybe there are still in outreach, is to utilize on the patient overview page, the Care Insights section. That is a real-time area in which you can add content. So if you are doing outreach, and we'll just say that, they're assigned to VOTC, but Chris is going to go in and she's going to see that member. If VOTC hasn't, added something and Chris goes in and adds something in there, both organizations, in fact, everybody will be able to actually log in, look at the patient overview page and see on there that, some type of engagement has been done. And it's honestly, there's a couple of different areas and it's really free text. So you can add content there. So that might be at least a place of communication in real time about engagement. And I agree with Toby about, hurry up and get your care plan in. Because then, of course, if you see a care plan, it's there and most likely there's already a process in place for outreach. But always happy to just brainstorm with you guys too.
Perfect. Thank you, Lisa. I'm curious if anyone, and Eric, I see your hand up. I'm curious if anyone has used that section, the Care Insights, and has any experience to share with that. Okay, so maybe something to try. Yeah, Eric.
Yeah, success first. So we've been able to successfully submit and get reimbursed with our 835s through our clearinghouse for all our payers, including ones that went live in some counties a couple weeks ago. The exception, the challenge for that is it's not one payer. We're rounding month 11 right now, and it's been a major challenge. All our clearinghouse is adamant that PHC is requiring a test file, and the test file is being rejected because PHC does not say they require a test file. And so yeah, that's a major problem for us, and I imagine for the plans too. It's going to show lower penetration rates. We're really hesitant to start drawing down our cited funds to expand our footprint in some of the partnership counties, because if we can't make the services sustainable, we don't really want to plant more staff there.
Yeah, can you, Ashley, I'm curious, I saw your face, it sounds like you're familiar with this barrier. Yeah, any thoughts to share on that?
Yeah, I was just thinking Eric is probably tired of seeing my name with this issue, because we've been working on it for what feels like forever. And I am not a billing expert, so I don't want to misspeak on the process and the barriers that they're running into. I was reacting because I was happy that it was able to go through, but if you're still experiencing issues, we definitely want to address those. So Eric, if you want to reach out to me offline, and I can loop Bonnie, who's our claims expert, in, and also our EDI team, we'll see if we can get to the bottom of it.
Great, thank you, Ashley. And Eric, I'm curious, I heard you say, you're reluctant to use the funds to expand services in this region. Is it just because of that billing barrier? Not to minimize it, but is that the primary reason, or are there other factors as well as you think about expanding services?
It's just the reimbursement. I mean, we don't want to employ staff in one of the partnership counties and then have them, not be sustainable. So yeah, sorry, I didn't mean to mislead you, Ashley. It's Kaiser. We've been rotating claims through already, which was wonderful, but our other payers 835s as well. So
awesome, thank you. Thanks for sharing your experience. Great. What about one of the things that we've heard in previous sessions is around just the administrative burden, and in particular, what can feel like duplicative, or not just feel like, what may actually be duplicative reports DHCS is requiring. So that's something that we're going definitely to uplift to the DHCS directly, but was curious in this group if folks had any feedback on that, in terms of just either recommendations or ideas for how to reduce administrative burden and particularly reduce reporting requirements for DHCS.
Reporting would be nice. I think if you could get all the managed care plans to have the same, what they call imports, IOTs, RTF, OTF, whatever the acronym is across the managed care plans, if those are all standardized, it would make reporting more consistent, I imagine, for DHCS and the payers. And then for CBOs that contract with multiple plans, they could have a single file that gets sent out to the respective payers, SFTP or whatever the portal is. That would be nice.
Great. Thanks. Any other thoughts on reporting? Yeah, Toby?
I just want to commend between partnership and point-click care from when we first started. It's pretty streamlined now, from getting the RTF to being able to report on point-click care, where at first it was this huge lapse of time to be able to get it in within the 60-day period. Now it's right after they do the reporting at the first of the month. We're able to get them now with the care plans within 30 days, unless they enroll at the very end of the month, and then we have to wait that probably 31, 32 days. But it's the administrative burden over these last 12 months since we've been doing it has definitely decreased. So
that's wonderful. So glad to hear that. So good to hear that. Great. All right. Okay, well, maybe we will go to our next lever then. Eva, if you want to share the slides, please. And so we're now we just finished lever 6, so this will be lever 5, which is all about strengthening market awareness. And so when we talk about market awareness, we're talking about both awareness in the community of, partnership members or potential partnership members who might be good candidates for ECM or CS services. So kind of that word of mouth, or that, piece of members being able to self-identify some of their needs, as well as the medical community who might be able to refer for ECM or CS services. So the questions that DHCS has put forward are: how are PHC and ECM and CS providers promoting general awareness about these services in the community? What strategies have been successful in training and promoting awareness with referring providers? So that's more the medical piece, medical community. And then what strategies have been successful in promoting awareness among Medi-Cal members? And in particular, what strategies and lessons from the COVID-19 pandemic can be leveraged here? And if that sounds like a little bit of a I don't know what my sports analogy is, but like out of left field, we were really thinking about this in terms of during the height of the pandemic, we really learned a lot it was very community and geographic specific about how to get the word out about important, updates and programs in given communities. And so in particularly, if we think about the Northeast regions and in particular the frontier counties, are there things that you all learned during the pandemic about how to communicate with and engage Medi-Cal members that might be good lessons that we could apply here related to ECM and CS? So those are our questions, and maybe I'll just copy them into the chat so that you have them. And Eva, if you want to bring all of our faces together again. Here we go. So yeah, thoughts on strengthening market awareness, either what's worked or just ideas that you have, or recommendations for what you'd like to see in terms of action or guidance from DHCS. It's another component. Yeah, Toby and Andrea.
So now that the pandemic extension is over for insurance for having to recertify, so on the partnership portal, you're able to look to see when the member has to recertify, but they've only made that eligible for primary care providers. If they could make that eligible for other network providers to be able to see that, because we're Visions of the Cross, we're having the more sessions with them than their primary care provider to be able to, like, we're meeting with these people several times a month saying, hey, you got to certify this month. But if there was a way that they could open up for just the ECM providers to be able to see when their recertification is, to be able to help with them in the recertification now, because we have a lot of members now that the pandemic is up, that because there's other than on that or contacting the social services offices, there's no other way for us to know when their recertification is due. So that would be helpful, I think, for a lot of people to be able to access that on the provider portal.
Yeah, no, it's a great point. In terms of the bare minimum of all of this is having active Medi-Cal, right? Yeah. And I'm curious, one of the things that I've experienced in other counties is that the redetermination dates aren't always accurate. And in particular, if the plan is getting the redetermination dates from county social services, depending on kind of what those systems look like, and that those dates aren't always accurate. So I'm just curious if in this region that has been an issue, if anyone's aware. Okay.
We've had good accuracy.
Okay, fabulous. That's great. Okay. Debbie?
So I'm from Partnership, and I just wanted to remind people that the plan doesn't have any control over the reinstatement. We don't have a list of when people are going to expire. It all comes to us from the state in a download every month. And so we feel very helpless also because we don't know when a person's going to drop off until they've dropped off. And then we just have to make sure people are aware that you have to go to the county Medi-Cal office to try to get them back on. So it's sort of a black hole because it leaves everybody in a lurch when a member either falls off or didn't get into that window of filling out their forms, but the health plan doesn't even get to have that information either. So it wouldn't be on our portal.
Debbie, thank you for that clarification, because I think this is something that differs by county. So that's really interesting. So the county office doesn't share the redetermination dates with partnership?
Not that I am aware of.
Okay. So then I wonder, to the extent that the primary care clinics have that data, do we know if they're getting that directly from the eligibility office? Or, I mean, I guess I would assume.
I would assume so, but are they able to really look at it and identify the members that are going to be falling off?
Right.
Because do the members actually go in every month or often enough for them to identify them? So that's what I mean about there sort of being a black hole.
Yeah.
The communication might be going somewhere, but it's not going where it needs to, if that's fair.
Right. Well, and kind of to Toby's point about if they as an ECM provider are seeing the members more frequently, that
They should be able to have that list.
Yeah. Great. Okay, that's definitely a DHCS recommendation that we can make. Wonderful. Areta?
Hi, good afternoon. Can you hear me? Yes.
Yes.
Hi. So one of the practices that we have adopted to avoid that kind of scenario, because we've had that too, where the member comes in and like halfway in the month they lose eligibility and so forth. One of the things we have done is, once we have engaged the member and the member says, yes, I'd like to be a part of the ECM program, we encourage that member to go to the eligibility office and to see if they're needing to re-verify the eligibility. That's one thing, because we find that just being a little bit more proactive with that point is helpful, or has been helpful. And again, because of the population that we service, a lot of them, if not all of them, are homeless. And so a lot of times they don't get the letter to re-verify, they don't get all of that information and so forth. And it does put a strain on, especially if they're in anyone coming to support, and like right in the middle of it, they're like, oh, we lost eligibility, then you know what. So we've been proactive in that approach. It doesn't always work, because sometimes the members don't always follow through. But that's one of the, if that helps in terms of strategy, is once we have a member enrolled, we just say, hey, when was the last time you looked at your eligibility? Do you mind going to the office and just checking to see if your verification is coming up, if that helps.
No, thank you, Areta. I think that's a great best practice. Of course, if there's a way systematically to do it so that we don't have to rely on the member and, ask them to take that time out. But certainly as a workaround, that's a great idea. Thank you. Eric?
Where we provide recuperative care, sobering center, and short-term posts, some of the partnerships with the county, they've funded eligibility workers coming on site a few days a month, which has been really helpful. But those have been pretty extensive long-term projects with the payers in those regions, the city and the county. And when that's available, it's really, it's helped fill the gaps quite a bit.
Absolutely. Can you speak a little bit more to that in terms of like who funds that? And yeah, just a little bit, because it sounds like, am I right in understanding that that's not happening in the Northeast regions as far as we know?
We don't do those CSs in the Northeast region, so
Okay.
It's hard for me to say for sure. Partnership probably a better position to answer, but in some of the middle of California where we do the per diem CSs, effectively what happened is the payer and the city split operating expenses with the understanding to transition to claims, and then the county has a vested involvement too, because they have like their behavioral health clients, and they support funding for like an eligibility worker coming on site.
Awesome. Okay, interesting. Thank you. It's great. It's always really helpful to hear about models that are working in other regions. So thank you. Let's see. Areta, did you have, is that you still your hand up from before, or did you have additional thoughts?
It was still my hand. Sorry, I need to put it down.
Oh, no worries. No worries. Just didn't want to miss you. Great. Yeah, I'm curious if other folks have best practices or things you've tried in terms of, trying to avoid loss of Medi-Cal eligibility for your clients. This feels like it's like a forever moving target. Yeah, Christina?
Yeah, so we actually have an advocate on site that helps us out with Medi-Cal re-eligibility. We have lots of different programs here that we oversee that interact with Medi-Cal in one way or another. And so we found actually having an advocate on site to help us with that and work with the county was what was really helpful for us. And so what we found also is the only way to really figure out their issue dates is by going to Medi-Cal's website directly. So we are looking at their eligibility there, usually before partnership, because at least we can see what their issue dates are and when it's going to look like it expires. So we have those flags inside of our system as well.
Got it. So based on the Medi-Cal eligibility website, then you estimate what's essentially 12 months out, like what is likely to be their redetermination date?
Yes.
Got it. Okay.
And then I put something else in the chat as well. And Lisa mentioned she may have a solution for it in Point Click Care, but it would be really helpful if we knew a little bit better what other people's populations of focus were, because I really think that there's lots of opportunities for us, even though we're all ECM providers, that we can work together as ECM providers, because your population of focus is because that's what your expertise is in. And so I would say if I have somebody who shows up here with substance use disorders, that's not necessarily a population of focus that is our strength. And so I'd rather get them set up with an ECM provider that it is more appropriate for. Whereas on the flip side, we really do a lot with readmissions and we do a lot with seniors here. So people who are transitioning out of a SNF and whatnot, and that is our area of expertise. So it would be really great building these relationships and in this meeting even that we can talk with one another and do some more handoffs of members that we think would be better fit for other organizations.
Thank you so much for that idea, Christina. I think that's great. And I'd be curious, we can kind of think also about whether this CPI space can help with that as well in terms of kind of getting clearer about who's doing what in terms of population of focus. Lisa, did you have a potential tech solution with Point Click Care to that issue?
I love coming up with solutions. I actually was just messaging Judy, who actually works with a lot of the providers. We have a network flag. I'm sure everybody's probably seen it because it says who the individual member is assigned to for ECM. We can include the population of focus in that. So that's a very customizable field, and it is displayed across the entire network. So our standard that we've used is just having the program name, hours of operation, phone number. But if we know what those populations of focus are, I'm going to actually ask Abby, who the project manager, to start asking our new providers for that information to add. But I think if we do a little level setting, we can go back and probably populate that for all the existing ones too.
Wonderful. I love a system solution. That's great.
There we go.
Thank you, Lisa. Ashley?
Yeah, just to add to that too, we actually had from the state as a managed care plan to start adding that to our provider directory. So we've been working with our PR department to provide the ECM providers populations of focus that they serve, and then the community support providers services that they offer. So it's been a little bit of a rocky start to just trying to implement these changes, especially with expansion. Sorry, my dog has a lot to say about ECM, but we're hopeful that we're in the right direction there, and that's going to be a great improvement on our website.
That's awesome. Yeah, that's really great. Well, and I'm even imagining that once PHC has all of that data, you might be the right link for Point Click Care in terms of getting it over there so they can have it in both places. Wonderful. All right. Well, any other thoughts about kind of how to increase market awareness, either among members or among providers? Any barriers in that area? I mean, I know there are a lot of barriers to increasing market awareness. And in particular, if you'd like to see, some different guidance or different action from DHCS around that. All right, well, I guess one last question on this one is, and part of it is my own personal curiosity, because during the pandemic, I did quite a lot of member awareness work in San Mateo County. So I'm curious, for the Northeast region, what did you find kind of worked and what didn't work in terms of getting messages out to folks? Who were kind of those trusted messengers that you identified, and what channels of communication worked better than others? I imagine there were some learnings. Yeah, Debbie?
To be perfectly honest with you, during the pandemic, there was little or no activity in most areas.
Okay.
And we had to respect that because we understood it. The offices were closed, the clinics were closed. People couldn't, you could get an appointment, and then it was usually a video appointment.
Mm-hmm.
And so I think that there was quite because there needed to be for safety of everybody, but there was a total disconnect. And so the more we tried to promote the beginning of CalAIM and our ECM product and our community supports product, I felt like we got a lot of pushback. We had people who were interested, but because of all the constraints of being locked up and shut down and all of that, it was one of those things where they were like, yeah, we'll get to it. Or when it's feasible, then we'll jump in and open up the program. But I think we stalled a lot in the beginning, because now we're going like gangbusters. And I think it's partly because everybody's out and about. And I think that all the things that we tried to do early on, which was fax blasts and talking to our providers and making sure that, DHCS did send out a lot of information to the members, several different things, but we also send stuff out to the members. And I believe probably 1 in 4 read them, or they read 1 in 4, because I think sometimes we send too many. But I think now the word is getting out, and it's one of those things where it's so on and so on. You tell your Aunt Martha, and Aunt Martha says, oh, the lady around the corner could really use that. And then it has a chain reaction. So now I think that word of mouth seems to have been our biggest asset, because when we do groups of people and we do a lot of presentations, especially since we just expanded, and so we feel like we've been everywhere at least 3 times, the people come and have a knowledge about it because they had other plans, but we're not starting at the very beginning anymore. There's a baseline.
Great, thank you. That's really helpful. And I'm realizing, in listening, Debbie, to your thoughts, and in seeing the chats from Andrea and Christina, I'm realizing that I was not at all clear with my question. I was meaning like that when we were in the pandemic, there was all this information, public health information, that needed to go out, right? About how does it spread, and where do you get tested, and if you want a vaccine, where do you get the vaccine? And like there was all of this information that needed to go out from the plans and from the local clinics. And so I was asking less specifically about ECM and CS, and how did that get? Yeah, that was not on anybody's radar, but more just what were the communication channels that were effective when you were trying to get out information to Medi-Cal members. So anyway, I'm realizing that we have to wrap up, but I just wanted to make sure that I clarified, and maybe we'll jump into that at our next meeting. So I'm gonna hand back over to Eva to wrap us up. But thank you for being here. Really, really appreciate this discussion. Been taking lots of notes, and we have it recorded, so we'll package it all together. But yeah, lots of gratitude for today. And on to Eva.
Thanks, Gabrielle, and thank you everyone for sharing. I think we learned a lot and I'm excited for the conversation to continue. So we're just going to touch on some next steps. We're going to do a couple more polls just to see what would be most helpful to you when we're thinking about moving forward in 2024. Again, really want to make sure that we're offering offerings that are really what you're looking for and really those that will help support you no matter kind of where you are in this journey. So I have just launched that poll, so if you can fill that out really quick. And I'll give it a few more seconds. Great, thank you for filling that out. That'll really help inform the following sessions. And then we have one more just to see what was the most helpful part of this session. If it was the level setting for 2024, updates about the DHCS policy, or the discussion on local feedback for DHCS. Again, that'll help us inform future sessions and make sure we're really elevating the sections that are most helpful and giving more time to those. All right. And it looks like the discussion on local feedback for DHCS was the most valuable part of today's session, and that's really helpful for us to know moving forward. So thank you very much for providing that feedback. And so looking forward to session 2 of 2024, the registration link for the February meeting will be sent out in the post-session email. So please be sure to fill that out. And then as we did with this session, you'll fill out that registration link, and then the Zoom link for the session will be added to the calendar invite and sent out the day of the session. Please continue working on your PDSA. Be sure to connect with us for one-on-one support or support through office hours. And speaking of office hours, they're happening right now. So right after this meeting, we're going to have an office hours with Visions of the Cross. Again, they can provide some support specific to applying for different funding sources. But if you have questions about anything pertaining to your contracting status or anything related to any of our topics, please feel free to come by. And future office hours dates will be shared in the post-event email as well. But it's always
sorry to interrupt. Do we have a date set for the February meeting yet?
Not yet. I'll send that out through, yeah.
Okay. All right. So stay tuned.
Yeah. But as always, we just want to thank everyone so much for taking the time to be with us today, provide your helpful feedback. And Gabrielle, do you have any closing thoughts?
No, I think that's it. I think I saw a hand go up, but now it's not there. So yeah, just thank you so much, everyone. We love these sessions where there's so much participation and engagement. This is really, really valuable. So hopefully you found it valuable as well. And if you have any thoughts or feedback for us about how you'd like these sessions to happen in the future, please, we are very open to that and want this space to be for you. So thank you so much.
Thanks, everyone. Take care.
Bye.